Okay. Let me ask you now about the blood supply of the gallbladder, the pancreas, and the spleen.
All right, let's dive into the blood supply of these organs, keeping it tight. Gallbladder gets blood from the cystic artery, usually a branch of the right hepatic artery off the liver's main supply. Veins drain into the cystic vein, flowing to the portal vein. Pancreas, fed by multiple arteries, splenic artery for the body and tail, superior mesenteric, and gastroduodenal arteries for the head. Veins, like the splenic and pancreatic duodenal, drain to the portal vein. Spleen, supplied by the splenic artery, a major branch of the celiac trunk, winding along the pancreas. Splenic vein drains it, merging with the portal vein. These vessels are key for oxygen and nutrient delivery, but they're also spots for surgical risks like bleeding. Want specifics on any of these or related issues?
Okay. Okay. And what about venous drainage?
The gallbladder's venous drainage flows through the cystic vein, which dumps into the portal vein, sometimes via small veins directly to the liver. The pancreas drains via the pancreatic duodenal veins and splenic vein, all feeding into the portal vein. The spleen's venous drainage is handled by the splenic vein, which joins the superior mesenteric vein to form the portal vein. These veins carry deoxygenated blood and nutrients to the liver for processing. Want more on portal vein issues or anything else?
Well, let's talk a bit about the innervation of the liver and the gallbladder. We have parasympathetic and sensory. Sorry, parasympathetic and sympathetic. Sorry, and sensory. Talk to me about the vagus nerve, the greater splanchnic nerve, and why they are what they are.
All right, let's dive into the innervation of the liver and gallbladder, focusing on parasympathetic, sympathetic, and sensory components, plus the vagus and greater splanchnic nerves. The liver and gallbladder get their nerve supply from the celiac plexus, a network around the celiac artery. Parasympathetic innervation comes from the vagus nerve, cranial nerve X, which promotes bile secretion and gallbladder relaxation. It originates in the brainstem, travels down the neck and chest, and influences digestion by stimulating smooth muscle and glandular activity. Sympathetic innervation stems from the greater splanchnic nerve, arising from the T5-T9 spinal segments. It inhibits bile flow and contracts the gallbladder, prepping the body for fight or flight by diverting energy from digestion. Sensory nerves, carrying pain and stretch signals, travel with both sympathetic via the greater splanchnic and parasympathetic via the vagus pathways, relaying info to the brain. Pain from the gallbladder often refers to the right shoulder due to shared nerve roots. The vagus is key for rest and digest functions, while the greater splanchnic nerve is wired for stress responses, balancing the autonomic control. Want more on nerve dysfunction or clinical issues?
Yeah. Let's talk a bit about pancreas and spleen innervation too. I'm a bit confused, kind of put it in a nice system so I can understand, to be honest.
All right, I'll organize the innervation of the pancreas and spleen clearly and concisely, tying it together with the liver and gallbladder for clarity, like a quick reference guide. I'll cover parasympathetic, sympathetic, and sensory innervation, focusing on key nerves like the vagus and greater splanchnic, as you asked. Pancreas innervation. Parasympathetic, vagus nerve, cranial nerve X, stimulates enzyme and insulin secretion. It originates in the brainstem, promoting digestion and blood sugar regulation. Sympathetic, greater splanchnic nerve, T5-T9 spinal segments, inhibits secretion and constricts blood vessels, reducing digestive activity during stress. Sensory, pain and stretch signals travel via the greater splanchnic nerve, often felt in the upper abdomen or back. Spleen innervation. Parasympathetic, sympathetic, and sensory innervation. Spleen innervation. Parasympathetic, minimal vagus input. The spleen's functions, blood filtering, immune response aren't heavily parasympathetic driven. Sympathetic, greater splanchnic nerve, via celiac plexus, controls blood flow and capsule contraction, mobilizing stored cells during stress. Sensory. Limited sensory fibers via the celiac plexus detect capsule stretch or pain, felt in the left upper abdomen. Liver and gallbladder. Recap for context. Parasympathetic. Vagus nerve boosts bile secretion and gallbladder relaxation. Sympathetic. Greater splanchnic nerve, T5, T9, reduces bile flow and contracts the gallbladder. Sensory. Signals via vagus and greater splanchnic nerves. Gallbladder pain may refer to the right shoulder.
Okay.
Why?
Remember, let's keep answers short. Let's talk about now lymphatic drainage. So we have celiac, lymph node, intestinal trunk, cisterna chyli, thoracic duct. Can you explain this order of things?
Lymphatic drainage from the gallbladder, pancreas, and spleen follows a clear path. The celiac lymph nodes, near the celiac artery, collect lymph from these organs. From there, lymph flows into the intestinal trunk, a major lymphatic channel. The intestinal trunk drains into the cisterna chyli, a sac-like reservoir at the lower spine, L1, L2. Finally, the cisterna chyli feeds into the thoracic duct, which carries lymph up the chest to join the bloodstream at the left subclavian vein. This sequence ensures waste and immune cells are filtered and returned to circulation. Want more on lymph issues?
I just don't understand this pathway. That's all. We have the splenic lymph nodes too, and other lymph nodes.
The splenic lymph nodes, located near the spleen's hilum, collect lymph from the spleen, filtering waste and immune cells. They drain into the celiac lymph nodes, which then send lymph to the intestinal trunk. From there, it flows to the cisterna chyli and up the thoracic duct to rejoin blood circulation at the left subclavian vein. This path clears pathogens and supports immune function, but blockages or infections can cause swelling or impaired immunity. Want more on splenic lymph issues?
That's all good. Alright. Let's jump topics. Let's talk about pharmacokinetics. Guys, watch our previous episode. We've also talked about pharmacokinetics. Today I'm going to focus a bit more on metabolism and excretion, whereas last time we talked about absorption and distribution. Okie dokie. So, can we talk about cytochrome P450 enzyme system?
All right, let's dive into pharmacokinetics, focusing on metabolism and excretion, specifically the cytochrome P450 enzyme system. The cytochrome P450 enzymes, or CYP450, are a family of enzymes mainly in the liver that metabolize drugs. They oxidize, reduce, or hydrolyze drugs, turning them into more water-soluble forms for easier excretion. Key enzymes like CYP3A4, CYP2D6, and CYP1A2 handle most drugs, but each processes specific ones. Think statins or antidepressants. This happens in the liver's smooth endoplasmic reticulum, often in two phases. Phase 1, CYP450 modifies the drug, and Phase 2, conjugation adds molecules like glucuronide. Excretion then follows, mostly via kidneys into urine or bile into feces. CYP450 activity varies by genetics, diet, or other drugs, affecting drug clearance speed too fast, the drug's ineffective, too slow, it builds up toxically.
Okay.
Want more?
So we have phase 1 and phase 2. So the drug might be active, inactive, toxic. We might have oxidation, reduction, hydrolysis. Phase 2, we might have drug solubilization by conjugation, glucuronidation, acetylation, sulfation, methylation. Explain to me why we categorize things the way we did.
We categorize drug metabolism into Phase 1 and Phase 2 to simplify how the body transforms and eliminates drugs. Phase 1 reactions, oxidation, reduction, hydrolysis, happen first, mainly via cytochrome P450 enzymes in the liver. These modify the drug's structure, often making it active, inactive, or even toxic, depending on the drug. For example, some drugs start inactive and need Phase 1 to activate. Others get toxic if metabolism is too slow. Phase 2 reactions, glucuronidation, acetylation, sulfation, methylation, add molecules to the drug, boosting its water solubility for easier excretion through urine or bile. We split them because phase 1 typically alters the drug's activity, while phase 2 focuses on clearance. This order ensures drugs are processed efficiently, balancing effectiveness and toxicity. Want specifics on a drug example or excretion pathways?
Interesting. Let's say we have a lipophilic drug, and in phase 1 it has to do with P450, which I still don't understand what it is. And then we have some products of oxidation, reduction, and hydrolysis, and we have phase 2, which is conjugation, which I don't know what it is, and we have water-soluble metabolite. Explain this process.
Alright, let's break this down simply for a lipophilic drug, focusing on cytochrome P450 and the metabolism process. A lipophilic drug, meaning fat-soluble, enters the body but needs to become water-soluble to be excreted. In phase 1, cytochrome P450 enzymes, a group of liver proteins, kick in. They perform oxidation, adding oxygen, reduction, removing oxygen, or hydrolysis, breaking bonds with water to tweak the drug's structure. This often makes the drug less lipophilic, sometimes active or toxic, creating metabolites. In phase 2, conjugation happens. Enzymes attach molecules like glucuronide, sulfate, or acetyl groups to the metabolite. This conjugation makes the metabolite highly water-soluble. The result is a water-soluble metabolite that's easily flushed out through urine or bile. P450 is key in phase 1 for chemically altering drugs. Conjugation in phase 2 is like tagging the drug for easy exit. Want a specific drug example or more on excretion?
Let's talk a bit more about phase 1. So let's say we have an active drug. Explain to me the oxidation of P450 cytochrome. I don't understand how the name relates to structure and function. This is a big problem I have with this P450 cytochrome. Tell me what a prodrug means. So it's metabolized in an active drug. For instance, codeine to morphine. Or levodopa to dopamine.
Alright, let's unpack phase 1 metabolism, focusing on cytochrome P450 oxidation and clear up the name structure function confusion, plus explain prodrugs. In phase 1, cytochrome P450 enzymes in the liver modify drugs through oxidation, which means adding oxygen or removing electrons to alter the drug's chemical structure. This makes the drug less fat-soluble, preparing it for excretion or further processing. For an active drug, oxidation might enhance, reduce, or stop its activity, depending on the drug. Now, cytochrome P450. The name comes from cyto, cell, chrome, color, and P450. It absorbs light at 450 nanometers when bound to carbon monoxide. Structurally, these are proteins with a heme group that use oxygen and electrons to break or form chemical bonds in drugs. Functionally, they oxidize drugs like a factory, adding hydroxyl groups to make them more reactive or polar. A prodrug is an inactive drug that needs metabolism to become active. For example, codeine is oxidized by CYP2D6 into morphine, the active painkiller. Levodopa isn't a classic prodrug, but crosses the blood-brain barrier and is converted to dopamine by enzymes, not P450, treating Parkinson's. The P450 system's role in oxidation is to chemically unlock drugs, active or not, for phase 2 or action. Want more on specific P450 enzymes or prodrug examples?
Tell me about cytochrome. So cytochrome P450 is a system that metabolizes a drug to make it active.
Not always. Cytochrome P450 is a group of liver enzymes that metabolize drugs in phase 1, mainly through oxidation, to make them more water-soluble for excretion. For some drugs, this activates them, like codeine turning into morphine, active painkiller via CYP2D6. But for others, it can deactivate them or make them toxic,
I see.
depending...
Let's talk about the inhibitors of cytochrome P450.
Cytochrome P450 inhibitors slow down or block the P450 enzymes in the liver, which handle phase 1 drug metabolism, mostly oxidation. These enzymes make drugs more water-soluble or activate prodrugs. inhibitors increase the levels of drugs metabolized by P450, risking toxicity or stronger effects. Common inhibitors include grapefruit juice, blocks CYP3A4, antifungals like ketoconazole, and antibiotics like erythromycin. For example, inhibiting CYP2D6 can cause codeine to stay inactive, reducing its pain-killing effect. Different inhibitors target specific P450 enzymes, like CYP3A4 or CYP2C9, altering drug clearance. Want examples of drug interactions or specific inhibitors?
There's a lot. And what about inducers?
Cytochrome P450 inducers speed up P450 enzymes in the liver, boosting phase 1 drug metabolism, mainly oxidation. This makes drugs clear faster, reducing their effects or duration. Common inducers include rifampin, targets CYP3A4, carbamazepine, and smoking, revs up CYP1A2. For example, inducing CYP2D6 can lower codeine's pain relief by quickly converting it to morphine and clearing it. Different inducers affect specific P450 enzymes, like CYP3A4 or CYP2C9, altering drug levels. Want specific drug interaction examples or more on inducers?
I want us to talk about therapeutic index and compare wide therapeutic margin with narrow. So basically this means that if the minimum toxic concentration is far away from the minimum effective concentration, then we can have a nice wide therapeutic margin. There's not many dangers of overdose.
The therapeutic index measures a drug's safety, comparing the minimum toxic concentration, where it harms, to the minimum effective concentration, where it works. A wide therapeutic margin, like with ibuprofen, means the toxic dose is much higher than the effective dose, so overdose risks are low, lots of wiggle room. A narrow therapeutic margin, like with warfarin or digoxin, means the toxic and effective doses are close, so even a small overdose can cause serious harm, needing careful monitoring. Want examples or more on dosing challenges?
So if I get a cytochrome P450 inhibitor together with a drug metabolized by cytochrome P450 with a narrow therapeutic index, why is there a potential adverse drug interaction?
If you combine a cytochrome P450 inhibitor with a drug metabolized by P450 that has a narrow therapeutic index, the inhibitor slows the enzyme, reducing the drug's metabolism. This causes the drug to build up in the body, pushing its concentration toward or above the toxic level. Since the gap between effective and toxic doses is small, even a slight increase can lead to harmful effects.
Yeah, but isn't it going to be inactive if the cytochrome P450 is inhibited?
You're asking about a cytochrome P450 inhibitor's effect on a drug, sticking to English as requested despite the Arabic phrase. If cytochrome P450 is inhibited, it doesn't become inactive but slows down, reducing how fast it metabolizes drugs. For a drug reliant on P450 to become active, like codeine needing CYP2D6 to turn into morphine, inhibition means less active drug is produced, so it stays mostly inactive and less effective. For drugs already active or with a narrow
why would that be unsafe in the case I described to you?
A cytochrome P450 inhibitor with a drug metabolized by P450 and a narrow therapeutic index is unsafe because the inhibitor slows the enzyme, causing the drug to accumulate. With a narrow therapeutic index...
Yeah, but it accumulates in an inactive form, no?
Not necessarily. For a drug with a narrow therapeutic index that's already active, like warfarin or digoxin, a cytochrome P450 inhibitor slows its metabolism, causing the active drug to build up, not an inactive form. This pushes levels toward toxicity.
How is it possible to be active before it goes through P450? I thought that was the whole point of P450.
Cytochrome P450 isn't always about activating drugs. Many drugs like warfarin or digoxin with narrow therapeutic indices are active when taken and don't need P450 to turn on. P450's role for these is to metabolize them, break them down into forms the body can excrete.
Okay.
If a P
Let's talk about genetic polymorphisms. Let's talk about the genetics and drug metabolism. So I want to understand extensive metabolizers, intermediate metabolizers, poor metabolizers, and ultra-rapid metabolizers.
Genetic polymorphisms are variations in DNA that affect how cytochrome P450 enzymes metabolize drugs, leading to different metabolizer types. Extensive metabolizers have normal P450 function, processing drugs at standard rates, so doses work as expected. Intermediate metabolizers have reduced P450 activity due to one altered gene copy, metabolizing drugs slower, which may need slight dose adjustments. Poor metabolizers have little to no P450 function, often from two defective gene copies, causing drugs to build up, risking toxicity, especially for narrow therapeutic index drugs like warfarin. Ultra-rapid metabolizers have overactive P450 enzymes, often from extra gene copies, clearing drugs too fast, reducing effectiveness, like with codeine failing to relieve pain. For example, CYP2D6 polymorphism affects codeine. Poor metabolizers get no morphine, while ultra-rapid ones risk morphine overload. Dosing must adjust to these genetic profiles. Want specifics on testing or a drug example?
I don't understand this shit, dude. What do you mean? So, explain to me how the name relate to the function.
I hear you. This stuff can be confusing. I'm guessing you're asking about how the name cytochrome P450...
No, dude. Extensive, intermediate, poor, and ultra-rapid.
Got it. Sorry for the mix-up. Let's clear this up. The names extensive, intermediate, poor, and ultra-rapid metabolizers describe how fast or slow someone's cytochrome P450 enzymes process drugs based on genetic variations. Extensive metabolizers, normal P450 function, drugs are broken down at the expected speed, so standard doses work fine.
Yeah, but why does extensive metabolizer mean that we have two active normal alleles?
The term extensive metabolizer means someone has two normal active alleles for a cytochrome P450 gene, like CYP2D6 or CYP3A4, because these alleles produce fully functional enzymes that metabolize drugs at a standard...
I see, and an ultra-rapid is a duplication of these normal alleles. I see. Okay, now it makes sense. Okay, let me ask about codeine phosphate and CYP2D6.
Codeine phosphate is a prodrug, meaning it's inactive until metabolized. CYP2D6, a cytochrome P450 enzyme, converts codeine into morphine, the active painkiller, through demethylation. Genetic variations in CYP2D6 affect this. Extensive metabolizers, two normal alleles, produce normal morphine levels, giving standard pain relief. Ultra-rapid metabolizers, duplicated alleles, make too much morphine too fast, risking overdose symptoms like breathing problems. Poor metabolizers, two defective alleles, barely convert codeine, getting little to no pain relief. Intermediate metabolizers fall in between, with reduced effect. This makes CYP2D6 testing crucial for safe codeine dosing. Want more on testing or other prodrugs?
I don't understand. So CYP2D6 is a polymorphism with ultra-rapid metabolizer. And, okay, so, wow, and, yeah, so do doctors know that we might have this? We have a lot of Ethiopian, Arab, and North Africans have this.
CYP2D6 is a cytochrome P450 enzyme with genetic polymorphisms, meaning its gene can vary, affecting how people metabolize drugs like codeine. Ultra-rapid metabolizers who have extra CYP2D6 gene copies convert codeine to morphine super fast, risking overdose. This trait is more common in certain groups, like some Ethiopian, Arab, and North African populations, where up to 10-30% may be ultra-rapid metabolizers due to genetic prevalence. Doctors can test for CYP2D6 polymorphisms using pharmacogenetic tests, like blood or saliva samples, to tailor dosing and avoid adverse reactions.
Question. So with N-acetyltransferase, So why is it genetically determined? And explain to me fast and slow acetylators and the risk of isoniazid hepatotoxicity, neuropathy, and drug-induced lupus with hydralazine. And why? I don't understand that. This is very arbitrary, these new words I'm learning.
N-acetyltransferase, NAT, is an enzyme, and its activity is genetically determined due to polymorphisms in the NAT2 gene. You inherit two alleles, one from each parent, and their variations decide how fast or slow you acetylate, add acetyl groups to drugs. Fast acetylators have two active NAT2 alleles, metabolizing drugs like isoniazid or hydralazine quickly.
Keep going. Keep going.
All right, we were talking about CYP2D6 polymorphisms.
No,
An
we're
ultra-
talking about the activity of N-acetyltransferase and why it's genetically determined, and what does slow and fast acetylators have to do with the risk of isoniazid neuropathy, isoniazid hepatotoxicity, and drug-induced lupus with hydralazine. And I asked you about the words because these words are really weird.
Okay, let's dive into N-acetyltransferase, NAT activity, its genetic basis, and how it relates to slow and fast acetylators, isoniazid neuropathy, hepatotoxicity, lupus with hydralazine, and clear up what you mean by whales. I think you meant wells or something else, so I'll assume you meant the Whale-Felix test related to drug metabolism or side effects. But correct me if you meant something else. N-acetyltransferase, NAT, is an enzyme, mainly NAT2 in the liver, that adds acetyl groups to drugs in phase 2 metabolism, making them water-soluble for excretion. It handles drugs like isoniazid for tuberculosis and hydralazine for hypertension. NA2 activity is genetically determined by polymorphisms, variations in the NAT2 gene. You inherit two alleles, and their combination decides if you're a slow acetylator, two low-activity alleles, or fast acetylator, at least one high-activity allele. Slow acetylators, common in Europeans, many 50%, metabolize drugs like isoniazid and hydralazine slowly, causing them to linger in the body, increasing side effect risks. For isoniazid, slow acetylators have a higher risk of peripheral neuropathy, nerve damage causing tingling, numbness, because the drug and its metabolites build up, toxic to nerves. They also face higher hepatotoxicity, liver damage, as unmetabolized isoniazid stresses the liver, raising liver enzyme levels or causing jaundice. For hydralazine, slow acetylators are at greater risk of drug-induced lupus, an autoimmune condition with joint pain and rashes due to prolonged drug exposure forming reactive complexes. Fast acetylators, more common in East Asians, many Asians, clear these drugs quickly, reducing toxicity risks
So a
but
fast
potential.
acetylator means we have a better P450.
No, a fast acetylator doesn't mean a better cytochrome P450. NAT2 and cytochrome P450 are separate enzyme systems. Fast acetylators have high NAT2 activity due to genetic variants.
But it's the same type of thing.
I get what you're saying, but NAT2 and cytochrome P450 are separate enzymes. NAT2 and cytochrome P450.
But they do the same thing. They break down things to excrete them.
You're right that both NAT2 and cytochrome P450 are NAT2 and cytochrome P450 help the body process drugs for excretion, but they work differently. Cytochrome P450, phase 1, modifies drugs through oxidation, reduction, or hydrolysis, often making them more reactive or slightly water-soluble. NAT2, phase 2, adds acetyl groups to drugs or their metabolites, making them much more water-soluble for excretion via urine or bile. Think of P450 as chemically tweaking the drug first, while NAT polishes it for easy flushing. For example, P450 might oxidize isoniazid, then NAT acetylates it to speed clearance. Fast acetylators, high NAT2, or rapid P450 metabolizers both clear drugs faster, but on different steps. Want me to clarify with isoniazids?
Yeah. Explain the different steps. And then I want us to talk about non-saturable metabolism, first order and second order kinetics, and explain to me the graphs when we have rate of drug metabolism on the y-axis and on the x-axis drug concentration.
All right, let's break down the metabolism steps for a drug like cytochrome P450, then dive into non-saturable metabolism, first order and second order kinetics, and those graphs with rate of drug metabolism, y-axis versus drug concentration, x-axis, keeping it short and clear. Isoniazid metabolism steps. 1. Phase 1. Cytochrome P450. Isoniazid, used for tuberculosis, first hits cytochrome P450 enzymes, mainly CYP2E1, in the liver. P450 oxidizes isoniazid, tweaking its structure to form metabolites like hydrazine. This step makes it more reactive, but not yet ready for excretion. 2. Phase 2. NAT2. NAT2 acetylates isoniazid or its metabolites, adding an acetyl group to form acetyl isoniazid. This makes it highly water-soluble, ready for excretion in urine or bile. Fast acetylators, high NAT2 activity, do this quickly, reducing toxicity. Slow acetylators let it linger, raising risks like neuropathy or liver damage. Non-saturable metabolism, first order and second order kinetics. Non-saturable metabolism. Enzymes like P450 or NAT aren't overwhelmed by normal drug doses. They keep metabolizing proportional to the drug's concentration without hitting a max capacity. First order kinetics. Most drugs, like isoniazid, follow this. The metabolism rate is proportional to drug concentration. Double the drug, double the rate. Enzymes aren't saturated, so a constant fraction of the drug is cleared per unit time, e.g., 10% per hour. On a graph, rate of metabolism on y-axis, drug concentration on x-axis, it's a straight line with a steady slope, showing the rate rises linearly with concentration. Second order kinetics. Rare for drugs, this happens when metabolism depends on two molecules, e.g., drug plus co-substrate or enzymes are saturated. The rate isn't just proportional to drug concentration, but to its square, or another factor. On a graph, it's a curve, not a line, often flattening as concentration rises due to enzyme limits. Think alcohol at high doses, where metabolism maxes out. Graph explanation. First order graph. Y-axis vertical tick, rate of metabolism versus x-axis drug concentration, shows a straight line through the origin. As concentration increases, the rate keeps climbing linearly because enzymes handle more drug without maxing out. Example, isoniazid at normal doses. Second order graph. The line curves upward at low concentrations, rate rises fast, but may plateau at high concentrations if enzymes saturate, hitting a max rate. This is less common, but seen in drugs like phenytoin at high doses. Want me to sketch out a specific drug's kinetics or dive deeper into graph shapes?
That's so goody good. All right, guys, let's shift our focus for a bit from pharmacokinetics. We're coming back to pharmacokinetics to some pathologies, starting with pathologies of the gut. So, I want to learn about Barrett's esophagus.
Barrett's esophagus is a condition where the normal squamous lining of the esophagus, the tube connecting your mouth to your stomach, gets replaced by columnar epithelium, a tissue type more like the stomach's lining. This happens due to chronic acid reflux, GERD, where stomach acid repeatedly irritates the esophagus, causing inflammation and tissue change. It's a precancerous state, raising the risk of esophageal adenoidectomy, though most cases don't progress to cancer. Symptoms include heartburn, regurgitation, or trouble swallowing, but some have none. Diagnosis is via endoscopy and biopsy to spot the altered tissue. Risk factors include long-term GERD, obesity, smoking, and being male. Treatment focuses on managing reflux with proton pump inhibitors, lifestyle changes like avoiding trigger foods, and monitoring for cancer risk with regular endoscopies. In severe cases, procedures like radiofrequency ablation remove the abnormal tissue. Want more on complications or specific treatments?
Okay. So what are the risk factors of reflux esophagitis leading to Barrett's esophagus? Alcohol, high BMI.
Reflux esophagitis, where stomach acid irritates the esophagus, can lead to Barrett's esophagus if chronic. Key risk factors include high BMI, obesity increases abdominal pressure, pushing acid up. Alcohol relaxes the lower esophagus sphincter, letting acid reflux. Smoking weakens the sphincter and damages esophageal lining. Frequent GERD, persistent acid exposure, hiatal hernia, part of the stomach slides up, worsening reflux, and diet. Fatty, spicy, or acidic foods trigger reflux. Men, older adults, and those with a family history of Barrett's or esophageal cancer are also at higher risk. Want details on preventing progression or specific triggers?
Talk to me about sorry guys, sorry.
No worries, we're all good. You were about to ask about something after we covered Barrett's esophagus and its risk factors. What's next, another gut pathology or something else? Lay it on me.
I want to compare a normal large bowel mucosa, how the crypts look like, how the goblet cells look like, with one that has ulcerative colitis.
All right, let's compare normal large bowel mucosa with ulcerative colitis, UC, focusing on crypts and goblet cells, keeping it concise. Normal large bowel mucosa. Appearance. The mucosa is smooth, pink, and uniform, lining the colon and rectum. Crypts. These are straight, tube-like glands in the mucosa, neatly packed and extending to the muscularis mucosae. They look like test tubes under a microscope, with regular, parallel alignment. Goblet cells. These mucus-producing cells are abundant in the crypts, shaped like wine goblets, staining purple with PAS dye. They secrete mucus to lubricate and protect the bowel lining, evenly distributed. Ulcerative colitis, mucosa. Appearance. The mucosa is inflamed, red, and ulcerated, often with bleeding or pus, starting in the rectum and spreading proximally. Crypts. Crypts become distorted, irregular, and shortened due to chronic inflammation. You'll see crypt abscesses, pockets of neutrophils, and branching or atrophy, unlike the tidy tubes in normal mucosa. Goblet cells? Goblet cells are depleted in UC because inflammation and rapid cell turnover reduce their numbers. Less mucus production weakens the protective barrier, worsening damage. Staining shows fewer, smaller goblet cells. In UC, the mucosa's orderly structure is disrupted by ongoing immune attack, targeting the inner lining, unlike the normal mucosa's calm, organized setup. Want more on UC's progression or diagnostic features?
Explain to me risk factors for dysplasia in ulcerative colitis, and what is dysplasia?
Dysplasia in ulcerative colitis, UC, is abnormal cell growth in the colon's mucosa, a precancerous change that can lead to colorectal cancer. It's detected via biopsy and classified as low-grade or high-grade, based on cell irregularity. Risk factors for dysplasia in UC include long disease duration, risk rises after 7-10 years, extensive colon involvement, pancreas versus left-sided, chronic inflammation, persistent flares, primary sclerosing cholangitis, a liver disease linked to UC, family history of colorectal cancer, and younger age at UC diagnosis, longer exposure. Dysplasia forms because ongoing inflammation damages DNA, driving abnormal cell growth. Regular colonoscopies are key to catch it early.
Remind us metaplasia, hyperplasia, dysplasia.
Metaplasia, hyperplasia, and dysplasia are cellular changes, often linked to chronic irritation or disease like ulcerative colitis (UC). Here's how they fit together, keeping it short. Metaplasia, normal cells change to a different type to cope with stress. In UC, it's less common in the colon, but can occur elsewhere. EGZ, Barrett's esophagus, where
But in
esophageal
a few
cells...
words, what does each mean?
Metaplasia, cells change type. Hyperplasia, more cells grow. Dysplasia, abnormal cell growth.
So, okay. So, cells change type, more cells grow. Fucking hell, a bit confused here, dude.
I hear ya. It's a lot. Let's simplify with a quick analogy to nail these down. Metaplasia, cells swap jobs, like a chef becoming a baker to handle heat better. Think Barrett's esophagus, where esophageal cells turn stomach-like. Hyperplasia, cells multiply like a factory overproducing, making more of the same. In ulcerative colitis, inflamed mucosa might thicken from extra cell growth. Dysplasia, cells go rogue, growing abnormally, like a glitchy blueprint.
Okay,
In
cool. Now, let's talk about histology of Crohn's disease and also diverticular disease of barium enema.
Let's dive into the histology of Crohn's disease and the barium enema findings in diverticular disease, keeping it concise as you like. Crohn's disease histology. Crohn's is a chronic inflammatory bowel disease affecting any part of the GI tract, often the terminal ileum and colon. Histologically, it shows transmural inflammation. All bowel wall layers, mucosa, submucosa, muscle, serosa, are inflamed, unlike ulcerative colitis, which is mucosal. Non-caseating granulomas, clusters of immune cells, a hallmark, seen in 30% of cases, not in infections like TB. Crypt distortion. Glands in the mucosa are irregular, with abscesses or loss of normal tubular shape. Ulcers and fissures. Deep, linear ulcers and cracks penetrating the wall, leading to fistulas or strictures. Lymphoid aggregates. Immune cell clumps in the submucosa or deeper layers, driving chronic inflammation. Think patchy, skip lesions, hypochondritic felthy areas between inflamed ones, unlike UC's continuous damage. Diverticular disease on barium enema. Diverticular disease involves outpouchings, diverticula, in the colon, usually sigmoid. Barium enema, a contrast X-ray reveals diverticula.
So what is this thing, dude? What is this? Speak to us simple words.
All right, I'm guessing you're asking about the barium enema for diverticular disease, since we were just on that before the cutoff, and you want simple words.
Get on with it. And tell us about sessile polyp and pedunculated polyp, whatever that is. Stalk or no stalk.
All right, let's jump back in with simple words, covering the barium enema for diverticular disease, then cecal polyps, pedunculated polyps, and clearing up what you mean by P-do-you-nucleated or P-do-you-nu, since that's unclear. I'll assume you meant something like adenomatous polyps or a typo, but I'll focus on pedunculated polyps and clarify stock details. Let's go. Barium enema and diverticular disease. Diverticular disease means small pouches, diverticula, bulge out from the colon, usually in the sigmoid area. A barium enema is an X-ray where they fill your colon with barium, a white liquid, to make it show up on images. It shows diverticula as little round sacs sticking out from the colon wall, like bubbles. If inflamed, diverticulitis. You might see narrowed areas or abscesses, but it's less used now since CT scans are better. Cecal polyp is a growth sticking out from the cecum, the pouch where the small intestine meets the colon, on the right side of your lower belly. Polyps can be benign, like hyperplastic, no big deal, or precancerous, like adenomatous, which could turn into cancer. They're found via colonoscopy, not barium enema, which isn't great for small polyps. The pedunculated polyp, and stalk or no stalk. A pedunculated polyp grows on a stalk, like a mushroom with a stem, making it wobbly and easier to remove during colonoscopy. The stalk is usually a narrow bit of normal mucosa. Non-pedunculated polyps, sessile, are flat or broad-based, no stalk, sitting tight against the colon wall, tougher to cut out. Most cecal polyps are adenomatous or hyperplastic, and pedunculated ones are often adenomatous, with a higher cancer risk if untreated.
Okay,